Hi everyone, I am Dr. Tushar Kanti Nayak. I am an orthodontist. I have done my MDS from Tamil Nadu Government Dental College. I have cleared my membership exam from Royal College of Edinburgh. I am a diplomat Indian Board of Orthodontists. I am a diplomat and member in World Congress of Orthodontics. I am a fellow in Indian Society of Oral Implantology. I've been into teaching for almost like 14 years and as a PG guide for more than a decade. Now I am completely into my private practice and teaching for Osstem Implants India Limited. Mostly as an orthodontist, I come across a lot of patients who are into late adulthood who want to restore their aesthetics and function. But as an adult patient, lot of people come with other occlusal history like missing tooth. So slowly I've started treating a lot of patients who needs orthodontic treatment and as well as replacement of missing tooth. So I'm going to say you few things regarding combining orthodontics and dental implants. So let's go directly into the topic. It is about interdisciplinary orthodontics and restorative dentistry. So what do you mean by interdisciplinary orthodontics? Lot of adult patients are coming to orthodontic clinic for their restoration of the aesthetic and function. So adult patients cannot be treated the same way as a growing child or a young adult because adult patients come with some amount of occlusal history. They come with some missing tooth, they come with some amount of atresion, they come with some amount of abfraction, restorations and periodontal problem. So any adult patient should be treated with a team. So it is important that the patient is not treated as a team also, and the sequence of the treatment and timing of the treatment are also important. For any orthodontic patients or any restorative patient, we want to achieve an ideal occlusion, something similar to this. The anterior aesthetic has to be optimum and the function has to be also optimum so that it can have a long-term stability. So you need to make some changes in the treatment plan approach. So for that you need to change before you can make some changes. Any adult patients who are coming to your clinic, it needs a different approach. So there are many articles. One of the very famous article by Dr. Ashok Karad from India, who want to optimize the interdisciplinary orthodontics. So one of the most important aspect of interdisciplinary orthodontics is optimization of the treatment time, sequence and the protocols. So there are many articles, many protocols are there, but it should be patient centric also. So if you go to the different literatures, there are many guidelines for treating adult patients and trying to treat them with some amount of interdisciplinary approaches. If you see over the period of time, what are the kind of problems usually a orthodontic patient as an adult comes? One of the most commonest is loss of posterior tooth. So what is the sequel of loss of posterior tooth? There is mesial migration of the adjacent tooth or migration of the adjacent tooth, supra-eruption of the opposing arch tooth. So how do you tackle that? How do you tackle that before going for a replacement of the tooth? First, you need to treat the effects which have happened due to a long-term missing tooth. So for that, you need to correct the supra-eruption, you need to correct the mesial migration. But over the period of time, though aligners have come, but still it has got some amount of limitation in treating each and every patient. So, and all the patients doesn't want to wear a fully bonded and bended appliances also. So, if you come like a supraeruption of upper molars, a case, you just need to put few micro implants or mini implants and join it with some amount of intrusive force with the help of each end, and over the period of time you get some amount of intrusion. If you have to go as a conventional treatment for this kind of cases, you need to do a root canal and crown lengthening and reposition the upper arch or the opposing arch before going for a replacement of the tooth. But when you can do a minimal amount of orthodontics treatment over the extended period of 6 to 8 months, you get some amount of result where you can avoid this kind of problems and get a optimal outcome with the replacement of the missing tooth with the help of a Osstem GS2 implant and a PFM crowns. It is not only about the supraeruption. There are many times when there is a major migration. Then we have to make a decision whether you want to close the space or open up the space for replacement of the tooth. So how do you do it? When you want to do it, you can do it with the help of a loop, or you can do it with the help of a sliding mechanics. So when the space is adequate, only a minimal changes has to be made. It can be simply treated with the help of a sliding mechanics or a open coil spring. But when you are going for a treatment or going for an orthodontic treatment, before the start of the replacement of the tooth, you know the ideal occlusion, what is the shape and size of the tooth which you are going to restore in the final occlusion, and accordingly you do the necessary orthodontic treatment, and after that you go ahead with the replacement with the help of a dental implants or a bridge, but mostly with the help of a dental implant, and you get a final satisfactory result and outcome. So there are cases where you want to close the space, there are scenario where you want to open up the space. So if you can see on the fourth quadrant where there is major migration of the tooth number 4-7 completely, and at this point of time opening of that amount of space requires a extraction of the tooth number 4-8. So it was decided on that side to close the space. But you do orthodontic treatment, but what is the ideal time to replace the tooth with the dental implant on the opposing side? So these are the points I am going to discuss in my subsequent slides. So ultimately you go ahead with a T-loop and close the space on the fourth quadrant, and you open up the space to the right length in the opposing side and replace it with a dental implant and with a ideal occlusion. There are many times when a lot of adult patient comes not because of a missing tooth, but which are not extracted because of impacted tooth, and when the impacted tooth have a poor prognosis and it need to be removed. It cannot be brought into occlusion with the help of orthodontic treatment. So in those cases, how do you do it? So then also the patient needs some amount of orthodontic treatment. So you do the necessary orthodontic treatment, you remove the tooth and you replace the tooth. But there has to be a sequence of the treatment. You cannot just extract the tooth and replace it whenever you want. You need to finish the orthodontic treatment, you need to wait for the occlusion to settle down, then only you can go ahead with the restoration of the missing tooth. So there are cases where you do the necessary orthodontic treatment and replace it with a dental implant, and after that you get an ideal occlusion. Whenever you are thinking of an orthodontic treatment, it has to be always inside the envelope of discrepancy. You cannot plan an orthodontic treatment which are not physiologically or biologically feasible. As an orthodontist and an implantologist, I am going to describe a little bit about the role of orthodontists, how to treat, when to treat, and as an implantologist, when you go down for the replacement of the missing tooth and the sequence of the treatment. So I am going to start with a straightforward case in terms of orthodontics, when the patient has come down to you with the chief complaint of forwardly placed front tooths. So, but when you go down to the occlusal examination, you see that there is a lot of periodontal problem. There is some amount of missing tooth also, and the lower two anterior tooth are not there. It has been lost due to periodontal problem, and the two other remaining incisor also doesn't have a good prognosis. So when you go down and consult the periodontist and you start the treatment as a team. So it was decided to do the necessary orthodontic treatment with the extraction of all the first premolars, and as the two remaining incisors were of poor prognosis, it was decided to remove at the end of the treatment and replace it with the help of a dental implants. So here it comes as a unique challenge. When you want to do the orthodontic treatment, how much time you would like to wait after the necessary periodontal treatment? When you want to replace the missing tooth, maybe during the orthodontic treatment or after debonding. So all these decisions need to be taken before the start of the treatment, and it need to be discussed with the patient, and you need to communicate about the possible duration of the treatment and the cost involved in it. So after necessary discussion and necessary diagnostic work, the orthodontic treatment was started after necessary periodontal therapy, that is after 6 weeks of the periodontal therapy, because it didn't involve any amount of hard tissue augmentation. So the necessary periodontal therapy, if it is only restricted till a soft tissue management, then the orthodontic treatment can be started after 6 weeks. But if there is some amount of hard tissue augmentation, then the orthodontic treatment should be done at least 6 months post hard tissue augmentation. I will be coming down to these discussions in the later slides also. So after this, you do the necessary orthodontic treatment and go ahead with the treatment procedures. So, but as the patient needs a lot amount of retraction and intrusion of the anterior tooth, a orthodontic mini screws were used. It is Osstem orthodontic mini screws which were used as a temporary anchorage device to help the intrusion and retraction of the tooth. So once you have done the intrusion and retraction and you have come down towards the end of the treatment, you go ahead with you are trying to replace the missing tooth. It is not necessary that you wait till the debonding of the orthodontic appliances. Once you are towards the end of the treatment, when all the active tooth movements are over, you can go ahead with the replacement of the missing tooth with the help of dental implants. So, but do you need to go with the prosthesis immediately or should you wait? Ideally, during the orthodontic treatment, there is a rise in the amount of osteoclastic activity. So, doing any dental implants during active orthodontic tooth movement is not that much advisable. So, you wait till the active tooth movement to finish, and when it is towards the finishing and settling stage, you go ahead with the dental implants rather than waiting for the debonding process, because you need to leave it for around 12 weeks post implant so that the implant tends to osteointegrates also. So once you have done the dental implants, you have done the debonding, then you should wait at least 3 months till the periodontal ligament settling takes place before going for any final restoration. So if you are going for a final restoration, how do you manage in the intermediate time? So you go ahead with the finishing of the orthodontic treatment and give a temporary. It might be fixed or it might be a A6 denture, but you need to wait till the periodontal ligament settling takes place. So in that way, it gives adequate time for the placed implant to osseointegrate. Then you go ahead with the final restoration. The final restoration is done with the help of a pre-milled abutment. The two implants which are placed is Osstem TS3 implants, and after that you can do a temporization with a temporary abutment or a link abutment which is screw retained. But when you want to do a final restoration, it is always advisable to do it with a customized abutment. Then once you place the custom abutments and you place the restoration, and it is a very ideal outcome with orthodontic treatment which involves extraction of 4 premolars and replacement of the lower 4 anterior tooth. So if you go down with the sequence of the treatment, the patient's initial diagnostic workup was done and necessary orthodontic treatment was done with the help of extraction of 4 premolars, and a pre-adjusted edgewise appliance was used, and a temporary anchorage device, Osstem mini screws, are used for the retraction and intrusion. After that, you replace the lower anterior tooths with the help of Osstem TS3 mini implants, and after that you go ahead with the restoration of the prosthesis with the help of a customized abutments. So from a initial result to these final results, which are always functionally and aesthetically optimum, we get a optimal functional and aesthetic results. The importance of this whole treatment, that you need to do it as a team, and the sequence has to be well defined and the timing has to be well defined also. So if you see the initial frontal photograph and the final frontal photograph, there is marked change in the facial aesthetics, and the occlusion has also improved to a lot extent. This is only possible because you need to diagnose the case and decide the timing and sequence of the treatment. So here we usually are talking about a missing tooth. So many times, many adult patient comes to you, not the loss of tooth is not due to a periodontal disease, but a congenital missing tooth. Then you need to take a decision whether to close the space or you need to open up the space and replace it with the help of a dental implant. So a cases most common is maxillary missing lateral incisors. So there are few guidelines when you should be closing the space and when you should be opening the space. One of the most important guideline is given by Kokis, where they have said about few definitive treatment plans when you should be closing down the maxillary lateral incisor space. But most of the times, if you see the necessity, you need to open up the space. So you open up the space for missing maxillary lateral incisor with the help of a dental implant or with the help of a orthodontic treatment, and replace it with the help of a dental implant. Usually there is a missing lateral incisor on one side and there is a peg lateral on the other side. So it was decided to do the necessary orthodontic treatment, open up and replace it with the help of a dental implants. So most important, as an implantologist, you should understand when you should be replacing it with the help of an implant. If you are waiting too much time after opening up the space, the amount of alveolar bone is likely to shrink. If you are doing it too early, then there might not be adequate space for placing the implant, or the implant might not osseointegrate because of the active tooth movement or the osteoclastic activity which is going around the implant site. So ideally you should wait till all the active tooth movement are done. Then when the treatment is in the finishing or settling phase, you place the dental implant and replace the tooth at a later point of time. So, as Christian Coachman said, dentistry is biased towards education, but we see many great clinicians trying to get a good result, but we are not giving adequate time to diagnose the case. So ultimately, what do we mean by that? We are not planning the treatment completely. We are not timing the restorations. We are not planning the retention protocols. We are more oriented towards getting the final results also, which might not be a very stable result on a long period of time. So if you see a case like this, the patient has come down to you with a complaint of an unaesthetic smile. She wants to improve the smile, but on a closer look and doing a proper clinical examination, you find that apart from the unaesthetic smile, the spacing, both the maxillary lateral incisors are congenitally missing, and there is retention of the deciduous tooth. So, and when there is a missing maxillary tooth, the amount of bone is also deficient. So if you go down to this case in detail, it is a missing tooth number 1, 2 and 2, 2. Lack of mutual protected occlusion because of there is slight amount of malposition of the canine tooths, pigmentation of the gingiva, the zenith of the lateral incisors, definitely due to the absence of the permanent tooth, the zenith are not at a proper position, and deficient bone for the placement of the dental implant, if at all you want to open up the space and place the implant. But looking at the case in general, you know that from the very beginning that you want to replace the two missing lateral incisors. So we come down to the most important part of the diagnosis and treatment planning is also timing and which specialty will handle the case at what part of the treatment So first is missing tooth number 1, 2 and 2, 2. When to replace? Lack of mutual protected occlusion. How to restore the mutual protected occlusion? Midline deviation, definitely you would like to treat it with the help of a orthodontic treatment. Pigmentation of the gingiva. So you want to do a depigmentation. When you should be doing it? And who should be doing it? The zenith of the lateral incisor. Can it be restored? And deficient bone. How do you replace the deficient bone? So before the start of the treatment, it is very important that you need to communicate. Earlier, it was an analog mock-up what you used to do it, but with the help of a software, in this case a 3-step software, we have tried to give a maybe mock-up or a digital mock-up to the patient, and we have tried to explain the final outcome, how it is going to look at the end of the treatment, which might be helpful in motivating the patient to undergo the treatment and be a compliant patient during the treatment. So it was decided to first to correct the malocclusion, to create adequate space for the missing lateral incisors and take the canine back into the right position to create a mutual protected occlusion. So once a orthodontic treatment is done, we went ahead with the placement of the dental implants with the help of a bone grafting. So the bone grafting which was done in a layer. There was some amount of autogenous bone collected from the chin, and there is some amount of genogenic bone layering which has been done, and with that we have closed down with a membrane, and the second stage surgery was done after 16 weeks. But in the meantime, most of the orthodontic treatment were finished and only the settling and finishing phases were going on. So once we have come down to the second stage surgery, then we do the debonding and we give the retention, but we don't go ahead with the final prosthesis. The reason is because we would like to have some amount of retention timing to be completed so that the occlusal settlement takes place, the periodontal ligament settling takes place, and there is some amount of reorganization of the gingival fibers. So we go ahead with the temporization. The temporization was done with the help of a link abutment and PMMA crown, and it was screw retained. So once we have done the temporization, during this time we have done the depigmentation. Why we waited till this time? Because we wanted to debond, we wanted to do the temporization. Any soft tissue changes has to be done, should be done at this stage, because it will help to create the ideal amount of soft tissue, and it helps in some way of retention also, because in the same process you will be doing some amount of supracrystal fibrectomy also. So after this, after maybe another 3 months with the temporization, you get a very good pink gingiva, and after that you go ahead with the final restoration. If you can see the initial phase after the orthodontic treatment and you see the phase after the temporization, it looks proper zenith and soft tissue, and the retention also is done so that the chances of relapse are minimized. After that you take the necessary impression, but with the soft tissue treatment which was done post debonding and temporization, you have achieved a proper emergence profile or a zenith, which gives the outcome a more aesthetic result and a stable result also. Then you go ahead with the final impression procedure, and mostly it is a digital workflow only. You do the scans for the dental implants, you do prepare the veneers and do the scans, and there are 2 crowns for 2 missing lateral incisor and remaining 2 central incisors and canines. The veneering was done. Now at the end of this you can see where the lateral incisor had a deficient bone. Now you can see a good amount of soft tissue and a good amount of hard tissue around the missing lateral incisor, and ultimately you get this stable result, which was taken almost like a month post insertion of the final prosthesis. So the initial result was initial photograph or the frontal photograph was there, but when you go ahead with the final results, it looks aesthetically and functionally very stable. And if you see the interval photographs from the initial photograph to the final aesthetically and functionally stable results. So what do we learn from all these things? So coming down to the end and summarizing, there has to be a guideline about doing a restorative procedures post orthodontic tooth movement. So one of the most important thing should be kept in mind that any surgical procedures involving hard tissue like placement of the dental implants and doing any GBR procedure should be avoided during active orthodontic tooth movement, because during active tooth movement we understand that there is high amount of osteoclastic activity, so which is a detrimental factor in osteointegration. The second most important factor should be understood that any gingival and soft tissue procedures like maybe soft tissue augmentation, gingioplasty or depigmentation should be done either pre-debonding or during the temporization phase, because it will help in some amount of relapse with the help of a supracrystal fibrectomy also. Third most important point you should be maybe remembering is the final restoration should be done at least post 3 months debonding, because we need to give adequate time for the occlusal settlement. That means we understand from our experience that the periodontal ligament settling takes place at least 3 months post debonding. So if you are trying to do any final restoration immediately after debonding, it might not be a final settled occlusion. So it is wise to wait for at least 3 months or maybe 6 months till all the gingival fibers and periodontal ligament fibers reorganize to the maximum level. then you can go ahead and do the final prosthesis, so which will be in a very settled occlusion. And during the phase of this transition phase, one of the important factor you should note that the temporization should be preferably done with the help of a A6 denture if it is debonded, because it is not wise to give a Maryland bridge which might need to be debonded during the second stage surgery, during the impression procedure. So repeated debonding and rebonding, if you want to avoid, then you can go ahead with the A6 denture. And why not a RPD? Because sometimes it puts a pressure directly on the surgical sides, which might be detrimental to the osseointegration. I hope everyone gets some amount of take-home messages and start applying these factors in either interdisciplinary orthodontics involving dental implants or any restorative procedures. Thank you.